I want you to do something for me. Just sit back, take a deep breath in, and let it out.
It feels completely automatic, doesn't it?
Yeah, it really does. But while you were doing that, your body was actually relying on an incredibly complex, delicate, and honestly, sometimes a highly vulnerable system.
Right. It's a mix of mechanics and chemistry that we just totally take for granted.
Exactly. So welcome to our deep dive into respiratory and pleural disorders. Our mission today is to be your expert guides, mining through some pretty dense clinical pathophysiology and management principles to extract the most crucial knowledge.
And whether you are, preparing for a medical exam, trying to better advocate for a sick family member, or you're simply curious about how the human machine operates under the hood, we are going to bypass all that typical textbook fatigue.
Totally. We aren't just going to list what these respiratory diseases are. We really want to look at the why.
Exactly. Why they happen, the underlying mechanisms, and how they connect to the bigger picture of human health.
And to do that properly, we need to start small. We're going to begin our journey at the microscopic level, deep inside the lungs, and work our way outward. Okay, let's unpack this. When we look at the alveolar level, we are looking at millions of microscopic air sacs.
Millions of them. And they rely on a very specific balance of surface tension and air pressure just to stay inflated.
Right. Now think about what happens when that microarchitecture loses its internal pressure and those sacs they just completely collapse. You get a condition called atelectasis.
Which is incredibly common, especially right after surgery.
Oh yeah, because when someone is under anesthesia or they're guarding their abdomen because of incision pain, their breathing becomes really shallow and monotonous.
They aren't taking those deep, expansive sighs that naturally keep those alveoli propped open.
Yeah, and that low tidal breathing essentially traps alveolar air. Over time, that trapped air is absorbed directly into the bloodstream.
Right, and without a fresh volume of air coming in behind it to replace it, the physical structures simply cave in on themselves.
But the clinical prevention for this isn't some crazy high-tech intervention. It's actually a super practical, multidisciplinary approach.
Yeah, hospitals use a standardized protocol called the ICOUGH program. That's spelled ICOUGH.
Let's actually break down what that involves because it's a massive shift in how postoperative care is managed. So ICE is for incentive spirometry, using that little plastic device to visually measure and encourage lung expansion.
And C is for coughing and deep breathing.
O is for oral care, which we'll see is crucial for stopping bacteria from traveling downward.
U is for understanding, which just means comprehensive patient education.
Then G is for getting out of bed.
And finally, H is for head of bed elevation.
That whole bundle is critical because it represents a move away from passive recovery toward active respiratory physical therapy.
Exactly. Because if those collapsed, unventilated spaces in the lungs are just left sitting there, secretions start to pool.
And stagnant fluid anywhere in the human body is just a perfect breeding ground for microbial invaders.
Which brings us directly to pneumonia.
Right, where that stagnant fluid becomes inflamed and infected. Clinically, pneumonia is categorized heavily by location and timing because that basically tells you what kind of bacteria you're likely dealing with.
So you have CAP, which is community-acquired pneumonia.
Then there's HAP, hospital-acquired pneumonia, occurring 48 hours or more after admission.
And VAP, ventilator-associated pneumonia.
But there's also a purely mechanical failure variant called aspiration pneumonia. This is when stomach contents or oral flora bypass the vocal cords and literally go down the wrong pipe.
Which is exactly why keeping a patient's head elevated 30 to 45 degrees is such a remarkably simple yet effective way to prevent gravity from working against a vulnerable airway.
It's so simple but so vital.
What's fascinating here is how viral pneumonias, specifically COVID-19, completely upend our traditional understanding of respiratory distress.
Yeah, the rulebook just went out the window.
Right. If you look at typical acute respiratory distress syndrome, or ARDS, the progression is usually swift, and the patient's distress is really obvious. But a severe SARS-CoV-2 infection is entirely different.
Because the virus specifically targets ACE2 receptors.
Exactly, which happen to be highly abundant in the vascular endothelial cells and alveolar cells of the lungs. This creates a deeply concerning clinical presentation known as happy hypoxemics.
I want to pause on that concept for a second because the term happy hypoxemic sounds almost like an oxymoron.
It really does.
You're talking about patients whose blood oxygen saturation has dropped to a level that should mathematically induce a coma or at least severe panic and gasping.
But instead, they are sitting up in bed, maybe scrolling on their phone, reporting absolutely no feeling of breathlessness.
Is terrifying from a physiological standpoint.
It is, because the brain's normal alarm system, which is usually triggered by a buildup of carbon dioxide or an extreme drop in oxygen, just doesn't fire normally. The vascular damage is happening completely off the radar.
And because of that, a patient can seem relatively stable and then deteriorate with breathtaking speed.
Furthermore, the timeline to severe respiratory failure is stretched out. Typical ARDS usually happens within a few days of an initial insult. With COVID-19, that progression to severe ARDS can take anywhere from 8 to 12 days.
And the management strategies had to adapt just as radically. We saw the deployment of antivirals like remdesivir, but also a heavy reliance on prone positioning.
Physically flipping the patient onto their stomach for 12 to 16 hours a day.
Yeah, by putting them prone, you relieve the physical weight of the heart and the abdominal organs off the lungs. It allows those damaged, fluid-filled posterior bases of the lungs to finally expand and actually participate in gas exchange.
It's a perfect example of using gravity and anatomy as a medical intervention. But while we've spent the last few years hyper-focused on this modern viral threat, there is an ancient bacterial enemy that hasn't gone anywhere.
So what does this all mean? We have these rapidly evolving viruses, but we also have to confront a disease that feels almost historical to many of us in the West, yet remains a massive, enduring global catastrophe. I'm talking about tuberculosis or TB.
The global statistics on TB are genuinely
They
sobering.
really are. In 2017 alone, 10 million people fell ill with TB. And more shockingly, it's estimated that 1/3 of the entire human population is infected with the Mycobacterium tuberculosis. 1/3 of the globe.
When you look at the pathophysiology of a TB infection, it's essentially a prolonged siege at the cellular level.
A microscopic standoff.
Exactly. When a susceptible person inhales those specific mycobacteria, they travel deep into the alveoli. The body's immune system immediately recognizes the threat and sends in phagocytes and macrophages.
They engulf the bacteria, but they can't always kill it.
Right, so they build a wall around it, forming a protective shell called a gone tubercle.
And inside that walled-off tubercle, the material undergoes a process called caseous necrosis. It literally turns into a cheesy necrotic mass.
And the terrifying part is that the bacteria can lay dormant inside that calcified scar for decades without causing a single symptom.
Until the immune system weakens,
Yeah.
at which point the tubercle can rupture and the dormant bacteria activate and rapidly spread.
Which is why identifying who is carrying this dormant threat requires specific screening. Traditionally, medicine relied on the Mantoux skin test.
Where a purified protein derivative is injected just under the top layer of skin.
Yes, and a few days later, a clinician has to physically measure the size of the immune reaction, the raised hard area called the induration in millimeters.
But interpreting a skin bump leaves a lot of room for human error, plus the patient has to actually come back to the clinic to have it read.
That's exactly why the shift toward blood tests, specifically IGRAs like the quantiferon or T-spot tests, has been so vital.
They measure the immune system's reactivity to TB in a lab, providing a faster, much more definitive answer without requiring a follow-up visit.
But diagnosing it is really only the beginning of the battle. Eradicating active TB is an immense pharmacological challenge.
It requires a grueling 6 to 12-month regimen of heavy-duty antibiotics, primarily isoniazid and rifampin.
And 6 to 12 months is an incredibly long time to take medications that often have severe side effects.
Especially when a patient might start feeling totally healthy after just a month or two. The cough stops, the fever breaks, and the temptation to just stop taking the pills is huge.
Which is exactly how we inadvertently engineer a worse crisis. When patients stop taking their medication prematurely, the surviving bacteria mutate.
Leading to the terrifying rise of MDR-TB and XDR-TB.
Right. Multi-drug resistant and extensively drug-resistant tuberculosis. We are talking about strains of bacteria that no longer respond to our best, most reliable drugs.
So adherence to the treatment protocol isn't just about curing the individual. It's the most critical factor in controlling a global public health threat.
Absolutely. But bacteria and viruses aren't the only external threats we pull into our lungs.
No, there's an entire category of environmental and occupational lung damage known collectively as the pneumoconiosis.
Which translates essentially to dusty lung.
Historically, we associate this with silicosis from glass manufacturing or stone cutting, asbestosis from shipbuilding or demolition, and of course, coal workers' pneumoconiosis, widely known as black lung disease.
But it would be a huge mistake to view these purely as artifacts of the Industrial Revolution. The mechanisms of environmental lung injury are highly relevant today.
Yeah, consider EVALI e-cigarette. or vaping-associated acute lung injury.
The introduction of aerosolized oils and chemical flavorings into the deep lung tissue creates intense, sudden inflammatory responses.
Furthermore, we are seeing unique, severe respiratory disorders in veterans who served in Iraq and Afghanistan.
The exposures over there were incredibly complex.
You have individuals who spent years breathing in particulate matter from intense desert sandstorms, combined with the toxic aerosolized soot from massive open-air burn pits.
And we are seeing these veterans return home and develop conditions like constrictive bronchiolitis, where the tiniest airways become permanently scarred and narrowed.
And the tragic reality uniting all of these occupational and environmental diseases, whether it's from a coal mine, a vape pen, or a burn pit, is that they are incurable.
Once that mineral dust or chemical irritant triggers severe scarring and fibrosis in the delicate lung tissue, that architecture cannot be rebuilt. The damage is permanent.
Therefore, prevention, utilizing proper protective equipment, and eliminating exposure are the only true interventions.
Exactly.
Here's where it gets really interesting. Let's look at what happens when these chronic conditions or an acute trauma push the lungs past their breaking point. This takes us directly into the intensive care unit,
Where the stakes are as high as they get.
when the lungs can no longer perform their fundamental job of gas exchange. A patient enters acute respiratory failure. This isn't just a vague term. It is defined by very specific critical blood gas values.
It occurs when the oxygen in the arterial blood drops below 60 millimeters of mercury, and the carbon dioxide rises above 50 millimeters of mercury.
At that point, the blood actually becomes acidic.
Yes, this respiratory acidosis is toxic to the organs. The clinical interventions must escalate rapidly to compensate.
The initial step might be non-invasive positive pressure ventilation. We use tight-fitting masks, like CPAP, which delivers a continuous, steady flow of pressure.
Or BiPAP, which toggles between two different pressure levels for inhaling and exhaling.
But if the patient exhausts themselves trying to breathe through the mask, or their cognitive state declines, and they can no longer protect their own airway from choking, the medical team has to take over completely.
This means moving to endotracheal, or ET, intubation, passing a tube directly through the mouth or nose, past the vocal cords, and into the trachea.
And if the patient is going to need this support for weeks or months, they will undergo a tracheotomy to create a surgical opening in the neck for a shorter tracheostomy tube.
Maintaining an artificial airway requires a terrifyingly delicate balance. At the bottom of that ET tube or tract tube is a small inflatable cuff that seals the airway.
And the pressure in that cuff must be maintained exactly between 20 and 25 millimeters of mercury.
The stakes for that specific pressure range are incredibly high.
If the cuff is too loose, secretions from the mouth can just slide right past it down into the lungs, causing massive aspiration pneumonia.
But if you inflate it too much to prevent that, the pressure of the cuff cuts off the capillary blood flow to the tracheal wall.
And without blood flow, that tissue suffers necrosis. It literally dies and rots inside the windpipe. It is a constant, high-stakes, tightrope walk.
Once the airway is secured, the patient is connected to a mechanical ventilator. Modern ventilators are highly sophisticated, computerized systems that use positive pressure to force a calculated volume of air into the lungs.
And one of those critical parameters controlled by the ventilator is called PEEP, positive end expiratory pressure.
To really understand PEEP, think about the mechanics of a damaged lung.
Normally, when you exhale, the pressure in your airways drops to zero, but healthy lungs have enough elasticity to stay open.
In a severely diseased or fluid-filled lung, when the patient breathes out, those millions of tiny alveoli just slap shut.
It takes a massive amount of force to pry them open again for the next breath. PEEP solves this by leaving a calculated amount of positive pressure in the lungs at the very end of the exhalation.
It essentially acts as a microscopic stent, cropping those alveoli open so they don't stick shut. This vastly improves oxygen absorption and reduces the mechanical strain on the lungs.
The machinery is incredible, but focusing solely on the mechanics ignores a major paradigm shift in intensive care.
Because surviving the ventilator doesn't mean much if the patient's mind is lost in the process.
Being on life support is psychologically devastating. Patients are paralyzed or heavily sedated, unable to speak, their sleep cycles are destroyed, and they're subjected to a constant barrage of alarms and painful procedures.
To combat the severe psychological fallout, modern ICUs utilize the ABCDEF bundle.
This isn't about the lungs. It's about treating the whole human being to prevent ICU delirium and post-intensive care syndrome, or PICS.
Let's break that acronym down. A stands for awakening, meaning daily interruptions of sedative drugs to let the patient's brain clear.
B is for breathing trials, testing if the patient can manage their own airway.
C emphasizes coordination between the nursing staff and respiratory therapists.
D is for rigorous delirium monitoring.
E is for early mobility. We now know that getting a patient physically moving, sometimes even walking while still connected to a ventilator, drastically improves outcomes.
And finally, F is for family engagement, integrating loved ones into the daily care routine to anchor the patient's reality.
When it is finally time to liberate the patient from the machine, the weaning process is incredibly meticulous. You don't just pull the tube out.
Right, because a patient's respiratory muscles atrophy incredibly fast on a ventilator. They use techniques like a T-piece trial, where the machine stops pushing air and the patient breathes entirely on their own through the tube for short bursts.
Or they might use SMAV mode, where the ventilator guarantees a minimum number of breaths, but allows the patient to take their own unassisted breaths in between.
Slowly rebuilding their diaphragmatic strength, like physical therapy.
We've spent a lot of time inside the lungs and on the machines that inflate them, but we have to shift our perspective. The lungs do not exist in a vacuum.
They are encased in the pleural space, a microscopic fluid-filled gap between the membrane covering the lung and the membrane lining the inside of the chest cavity.
When those membranes become inflamed, you get a condition called pleurisy.
Because that space is so tight, the inflamed surfaces rub together like sandpaper every single time you take a breath. It causes a sharp, knife-like pain, and a clinician can actually hear a grating sound through a stethoscope, known as a pleural friction rub.
And if that pleural space fills up with an abnormal volume of fluid, it creates a pleural effusion. The fluid physically takes up space in the chest cavity, compressing the spongy lung tissue and preventing it from expanding.
If that fluid is infected and turns into thick pus, it progresses to an empyema. The mechanical fix for this mechanical problem is a thoracentesis.
A physician inserts a needle or a catheter through the back or side directly into the chest cavity to manually drain the fluid and relieve the crushing pressure.
Draining fluid from the chest cavity is a relatively straightforward physical intervention, but not all dangerous pressures in the chest can be drained with a needle.
If we connect this to the bigger picture, we run into a hidden, often lethal cardiovascular issue: pulmonary hypertension.
This is completely distinct from the standard systemic high blood pressure you measure on your arm.
Exactly. This is high blood pressure isolated entirely within the vascular bed of the lungs. It is defined clinically as a pulmonary arterial pressure greater than 25 millimeters of mercury at rest.
Because the blood vessels in the lungs are so tight, thickened, and resistant, the right side of the heart has to work overtime just to force blood through them to get oxygenated.
And the right ventricle is not built for that kind of heavy lifting. Over time, it enlarges, thickens, and ultimately fails.
This specific type of right-sided heart failure caused by lung disease is called cor pulmonale.
The pharmacology required to manage severe pulmonary hypertension is staggering. Patients are often placed on continuous intravenous epoprostenol.
This drug is a potent vasodilator, opening those tight pulmonary vessels. However, it has a biological half-life of less than 3 minutes.
Less than 3 minutes.
That means if the medication stops flowing, the effects wear off almost instantly and the pulmonary vessels clamp shut, causing an immediate life-threatening crisis.
Exactly why these patients require a surgically implanted central venous catheter and a portable infusion pump that they must wear and manage 24 hours a day, 7 days a week.
We also see the use of oral medications, specifically repurposed phosphodiesterase 5 inhibitors drugs like sildenafil, which also promote vasodilation in the pulmonary bed, though through a different chemical pathway.
Which brings us to our final and undeniably heaviest topic of the deep dive: lung cancer.
It remains the absolute leading cause of cancer-related deaths for both men and women. The pathology divides it into 2 major categories.
Small cell lung cancer, or SCLC, is incredibly aggressive, grows rapidly, and is almost exclusively linked to heavy cigarette smoking.
Then you have non-small cell lung cancer, or NSCLC, which accounts for the vast majority of all lung cancer diagnoses.
Staging and treating these cancers relies on the TNM system, evaluating the tumor size, node involvement, and the presence of metastasis.
But modern oncology has moved beyond just looking at the size of the tumor. We now look at its genetic makeup.
Identifying specific acquired genetic mutations within the cancer cells, such as abnormalities in the EGFR gene, allows oncologists to deploy highly targeted, personalized therapies rather than just broad-spectrum chemotherapy.
But the most empowering piece of information regarding lung cancer isn't about treatment. It's about early detection. The United States Preventive Services Task Force, the USPSTF, has a very clear screening recommendation.
They advise an annual low-dose CT scan, an LDCT for adults between the ages of 55 and 80 who have a 30-pack year smoking history.
To clarify that metric, a 30-pack year history means smoking 1 pack of cigarettes a day for 30 years, or 2 packs a day for 15 years. The math focuses on total exposure.
Even if an individual fitting that profile quit smoking 10 or 14 years ago, they are still in the high-risk window.
The reality is that lung cancer develops insidiously. By the time someone starts coughing up blood or experiencing chest pain, the disease has usually progressed to an advanced stage.
That annual CT scan is designed to catch solitary pulmonary nodules when they are microscopic, long before any symptoms appear.
We've covered a tremendous expanse of medical science today. We moved from the simple yet vital postoperative strategies to keep tiny alveoli open through the cellular battlegrounds of tuberculosis and the chemical burns of vaping.
We've navigated the alarm fatigue of the intensive care unit, decoded the mechanics of life support, and explored the complex pharmacology of pulmonary hypertension and cancer staging.
And the goal of navigating all of that is empowerment. Whether you are walking into a clinical rotation trying to decipher what a doctor is telling you about a loved one in the ICU, or just wanting to understand the magnificent, fragile machinery of your own chest, you now have the vocabulary.
You understand the why behind the interventions. You know why the head of the bed is elevated, why the ET tube cuff pressure is so meticulously managed, and why we utilize PEEP on a ventilator.
Exactly.
This raises an important question. For the last century, our understanding of lung pathology was dominated by cigarette smoke, coal dust, and asbestos. They were the undisputed villains of respiratory health. While those threats certainly still exist, the environmental and occupational landscape is radically shifting.
So, as you take your next breath, as automatic and effortless as it feels right now, ask yourself, what will the black lung of our modern generation turn out to be? With the proliferation of novel, chemical inhalants, microplastics, and changing global environments characterized by burn pits and massive wildfires, how will the medical professionals of 2076 look back on the air we are choosing to breathe today? Keep asking questions, keep looking deeper, and we'll catch you on the next deep dive.